Thank you very much for that welcome, and thank you for inviting me to come and speak to you today. It's a great pleasure. And when I look at the list of people that have spoken here, you've obviously got a lot of pulling power, so it's a great pleasure. And I'm sorry that you spent 17 days unsure of who you might be inviting, and I'm very delighted that I am still the Health Minister in the Gillard government, because it means that we can continue with our important work of health reform, which is what I want to talk to you about today. But can I also acknowledge the traditional owners of the land, the Noongar people. Thank, of course, John and Jeanette for introducing us and welcoming everyone. I'm delighted that Professor Fiona Stanley is here, and of course Mike Daub, who has worked so closely with us on our preventative health strategy. And you obviously cross all political spectrums here. You said in your introduction that you had Kim Hames previously speak to you, today me as the Federal Minister, but you also have the opposition health spokesperson from the state here, Roger Cook, and Janine Freeman, the state member for Nollamara. And I understand that Senator Judith Adams is here. I haven't seen her yet, but hi Judith. So we've got a broad church, which I think is a really great sign when you want to be a organisation that provokes thought and discussion and debate. Being able to cross not just different professional groups and have students and leaders and others in the community, but to have people across the political spectrum is important too. I'm calling my speech today Succeeding to Reform the Health System, because we are absolutely determined that we will succeed in this aim. We don't believe there is an option to not reform the health system. And today gives me an opportunity to talk to you about some of the challenges that we face in order to do that. And as I say, it's a great opportunity to be able to speak to the John Curtin Institute for Public Policy. And I guess you would expect me in passing to note that, of course, John Curtin, as a hero of our party, was one of the greatest Prime Ministers. And while he is most fondly and profoundly remembered for his role in protecting Australia during World War II and forging an alliance with the United States, he also actually played a huge role in the development of our social services and in particular healthcare. It was the Curtin government that started our path towards the strong public health system that we have today when they introduced legislation to establish the Pharmaceutical Benefits Scheme, now of course a foundation block of our health system. As Curtin's Health Minister, Senator Fraser, said in January 1944, and I quote, "The scheme is the first step in a long-range medical and health program which the government proposes shall eventually include the provision of all medical and hospital services at the public cost." Now, it won't surprise many of you in this room to discover that his reforms did not actually face an easy path. They were challenged by the then British Medical Association in the High Court and found to be unconstitutional. It was only after a referendum, another successful High Court challenge, a change of government, limited early implementations, and 16 years later, that the PBS that we know today was finally established. But it was the hard work by the Curtin government against huge opposition from the establishment of the medical community that led to the PBS. So I tell this story just to demonstrate how hard health reform is in Australia, how hard it is to achieve, how hard it is to pay for, and how hard it is to implement. But through the tough reforms to the health system that Labor has implemented, whether it's the PBS, Medibank, Medicare, we now have one of the best health systems in the world. And whilst we should be proud of it, we can't be complacent. Patients around Australia know that further improvements can be made, and those of us with an eye to the future will know that the ageing population and increase in patients with chronic diseases is going to cause us great challenges in the future if we leave things as they are. That's why the government took the decision in 2007 that we needed to face these challenges head on, and we undertook a major but very methodical process of reform. We first of all gained the evidence from the experts, a specially established Health and Hospitals Reform Commission, a specially tasked preventative task force, and a group focused on primary care. We took the major recommendations on the road, consulting over 100 communities on their reactions to the proposed reforms. We released a response and negotiated a landmark agreement with 7 states and territories. Of course, there is one absent signature on that agreement, but I will get to that a little later. This was followed by a federal budget providing for our reform investments and topping it up with direct workforce, e-health, aged care and primary care investments. So what we did was go through a proper policy development process. It was open, it was evidence-based, and it focused on addressing the problems of the future. It enabled us to achieve an agreement that would have been very hard without the years of hard work behind it. But, as I said, there's certainly no doubt that we've faced challenges and will continue to face challenges, just as the Curtin and Chifley governments did over 6 decades ago. And I think it's also important when we discuss this debate to acknowledge that our challenges are actually similar challenges to those being faced by overseas governments too, such as the Obama health reforms in the United States or even the Blair government's reforms to the NHS. But we are determined to tackle these challenges because we believe the alternative is quite a dangerous one. To ignore these challenges will deliver a poor outcome for Australian patients. We won't be able to combat the increasing rate of chronic disease that could cripple our health services. We will still have differing public health systems and providers shunting patients around the system for financial, bureaucratic and uncoordinated reasons. We won't be able to combat the number of medication and other errors in our hospitals and health systems. And the states will be under mounting pressure over time as health costs gobble up an ever-increasing share of their budgets. And while I'm not going to cover each and every detail today, I do want to go over the main features of our reforms which, as a result of the COAG agreement with 7 of the 8 states and territories in April this year, represent some of the biggest changes to the health system since the introduction of Medicare several decades ago. First and foremost, our reforms are aimed at ensuring the system is better funded, better run and more sustainable into the future. We will be funding a majority share of hospital costs, including a fixed 60% share of the efficient price of all hospital services. In doing so, we are taking a much greater responsibility for health funding and a greater share of growth in our health costs into the future. Secondly, we want to drive important improvements to hospital services through more accountability and transparency than ever before. Through activity-based funding, the Commonwealth will pay hospitals for services that they actually provide. We'll set tough national standards backed by financial rewards for the states who perform well against them, which will drive improvements in waiting times and the quality of care. We're introducing much greater accountability through reforms such as the My Hospitals website, which will show all Australians how well their hospitals are performing. I was delighted to be able to announce just on the weekend that despite the fact that they aren't yet part of the broader health deal, Western Australia will now participate in the My Hospitals website. And all of this, of course, will be underpinned by much more local input through local hospital networks, and I'll get to Medicare locals later. In this audience, I do want to dwell a little bit on the public policy significance of these aspects of our reforms, just for a moment. Take activity-based funding as an example. Currently, the Commonwealth provides its funding contribution for public hospitals to the states through a block grant. States and territories then determine how much funding individual hospitals and health services receive. Through the Commonwealth, the taxpayer outlay is huge. We outlay an awful amount of money, of your money as taxpayers, but we don't know with any certainty what services that funding contribution buys or where the money actually goes. Under activity-based funding, for the first time, the Commonwealth will provide its funding contribution on the basis of the number of services that are actually delivered. The Commonwealth share will be fixed, as I said, at 60% of the efficient cost of each hospital service. And efficiency will be vital, but it also means, of course, that we are taking on the share of the growth as the demand increases or as the population moves. And importantly, the efficient price will be set by an independent hospital pricing umpire, operating completely at arm's length from the Commonwealth and state governments. Its role will be similar to that of the Independent Reserve Bank. I think I wrote that before yesterday's price increase. Maybe that's not a popular comparison to make today, but I think the independent role is important, of course. They have an independent role in setting monetary policy, and we believe that it's important to have an independent body to set an appropriate price. The umpire's ruling will be final, and the Commonwealth will pay its fixed 60% share of hospital services on this basis. This is a very significant health and economic reform for Australia. Even in those states where some type of activity-based funding already exists, such as my home state of Victoria, the activity-based price is still set by government. Charging an independent arm's-length umpire with this task will bring an unprecedented level of transparency to the pricing of hospital services and therefore the government funding which flows for these services. And just as governments don't interfere in the interest rate decisions of the Reserve Bank, governments will not interfere with the decisions of the independent umpire on hospital prices. And just as the Reserve Bank has provided for the stability and robustness of the Australian monetary policy for decades, I'm confident that the work of the independent umpire will provide a similar level of stability and robustness for the financing of our health system. The critical importance of moving to this system of activity-based funding, which was one of the key recommendations, by the way, of the National Health and Hospitals Reform Commission, is in its capacity to improve the efficiency and transparency of our public hospitals. It will improve transparency because, under ABF, we will know exactly what our massive investment, or more correctly, what taxpayers' massive investment in hospital services is buying for the public, how many services, where they're being delivered, in what time, and so on. And they'll improve efficiency because by introducing price signals into the provision of hospital services, providers will have an incentive to deliver services at or under an efficient price. Of course, this must go hand in hand with strong national clinical standards and guidelines so that efficiency doesn't ever come at the expense of the quality of care. And by funding our hospitals on the basis of activity, we can ensure that the funding will follow the growth in services delivered. So when the population grows in a particular area, such as the massive Perth population growth at the moment or mining areas in WA, then the Commonwealth will pay hospitals in those areas more money that they can spend on recruiting more doctors and more nurses and providing the services that are needed. As well as improving overall efficiency, activity-based funding can improve system performance and the quality of services provided to patients. For example, by explicitly linking funds allocated to services provided, it allows for easy identification of underperforming providers so the cause of that underperformance can be remedied while lessons from high performance can be shared. We believe these changes in themselves will deliver improvements to the system in the short and medium term, but they'll also drive very important changes beyond that by establishing the right incentives in the system for the Commonwealth to also invest properly in primary care and prevention long term. This is because for the first time we'll be picking up the majority of the tab for expensive hospital treatment if we don't get our investments in the front end right. Which brings us, I think, to the other very major part of our reforms. Whether it's investing in new types of care like subacute care, including 1,300 palliative, rehabilitation and mental health beds, and very importantly, investing heavily in prevention and primary care to keep people out of hospitals. For example, this is through establishing more GP super clinics, such as the ones in Wanneroo, Coburn and Midland, and now other sites like Rockingham, where I was this morning, investing in primary care infrastructure more generally, investing in after-hours care, establishing Medicare locals which will bring together and better coordinate primary healthcare services, and investing in prevention, such as through our world-leading tobacco reforms to introduce plain packaging of cigarettes. I'm going to be speaking tomorrow here in Perth as well about the primary care reform, so I'm going to save a little bit of that detail for then, but I'm happy, of course, to answer any questions on those issues as well. Fourthly, we know that we won't be able to pursue any of these reforms if we don't have the workforce to implement them. Workforce shortages are a problem around the country, and I know that they are an acute problem in many parts of Western Australia. And that's why we're investing much more than ever before in training more undergraduate doctors and nurses, in providing clinical training support for health professionals, including our recent announcement of $425 million to expand clinical training capacity into non-traditional settings, and better supporting health professionals to work in rural and remote areas. And of course, reforms that will make smarter use of our workforce, like the Medicare and PBS rights for nurse practitioners and midwives, which just came online only several days ago. And fifthly, we want to make sure that we modernise the health system for the future through electronic health records for all Australians, which will be critically important in assisting nurse practitioners or others to work collaboratively with our doctors and other health professionals in ensuring information about their patients is accessible and up to date. We want to massively expand telehealth through Medicare rebates for online consultations, which I know will be of particular benefit to the many rural and remote communities in Western Australia. And through innovations like e-health and telehealth, of course, we hope to fully utilise the power of the national broadband network to improve health service delivery. And I know with our colleagues here from universities that the universities are already showing much interest in these sorts of changes. So even with that thumbnail sketch, our reforms are expansive and ambitious. They have met with an extraordinary level of support, actually, from a wide range of stakeholders. But as with all reforms, they haven't been universally endorsed, especially by our political opponents. As was the case in John Curtin's time, many of our reforms have met with pretty stiff political resistance. Despite being a former health minister, during which time he often mused about the potential benefits of the very reforms we are pursuing, such as the Commonwealth taking greater responsibility for hospital funding, activity-based funding for hospitals, and greater transparency and accountability, the current leader of the opposition seems determined to be a wrecker when it comes to these reforms. Remarkably, the coalition voted in the lower house last week against legislation to establish a permanent Australian Commission on Safety and Quality in Healthcare, the very commission, in fact, that Mr Abbott set up on a temporary basis when he was the minister. The Permanent Safety and Quality Commission will work to drive improvements in safety and quality of healthcare provided in our hospitals and in other health settings. And particularly for some of you who may not be working in hospitals or following this in detail, let me just give you a little snapshot of why something like this is so important. 1 in 30 adults who goes into hospital contracts an infection while they are there. 12,000 of these people acquire bloodstream infections, and about a quarter of those patients die, a figure which is around twice the national road toll. So this is not a small problem that we are trying to tackle, and it's just one of them that the Quality and Safety Commission can help with. And yet the federal Liberal and National parties voted against the establishment of a permanent body to address these problems. But in good news from our new Parliament, I was very pleased that despite this approach from the Liberal opposition, the bill still passed the lower house with the support of all 6 crossbenchers, the first bill in the current Parliament to do so. So whilst I do expect some more political intransigence from the federal opposition, we do hope for a fair hearing and approach from the crossbenchers, as we have seen last week. We haven't let, of course, the negativity from the opposition put us off. Since the COAG agreement in April, we've been very hard at work, sleeves rolled up, getting down to the business of implementing and bedding down these reforms. As I said, despite the challenges we face in the current Parliament, the legislation of our reforms is going full steam ahead. As well as passing the Safety and Quality Bill, we've also passed a bill to establish the National Preventative Health Agency legislation last week, and the Treasurer introduced the Federal Financial Relations reforms, which provide that all-important framework for health reforms. Medicare Locals, the primary healthcare organisations which will help drive better integration and coordination of primary care services, will be one step closer when we open expressions of interest for the first of these in the very near future. We've been working steadily on the establishment of local hospital networks with the states and territories, and our investments in hospitals, in emergency departments, elective surgery and subacute beds are already rolling out across the country. In fact, we've already announced hundreds of new subacute beds across the country, although unfortunately none here yet in Western Australia. Which of course brings me to the elephant in the room. I am, of course, disappointed that although Western Australia has agreed to health reforms, it hasn't yet signed up to them like the other states have. I'm disappointed because as Health Minister, each time I come to Western Australia, I see how the state's health system could benefit from the reforms that we are pursuing elsewhere and the money that is on the table to go with them. I see problems that are continuing to happen in the health system, the stories that don't stop, deaths in regional hospitals that have prompted investigations into whether care was appropriate, delays in scanning and surgery for breast cancer, capital works projects delayed, health IT projects delayed or criticised by the Auditor-General, and elective surgery and emergency departments targets not being met. Now, I don't pretend for a second that the rest of the country doesn't have problems. Of course they do. But the point is, courtesy of the COAG Health Reform Agreement, every other state and territory is on the path to trying to fix them. Western Australia is not. It's also important, I think, to correct some other misconceptions that have been allowed to flourish in this debate. Perhaps most significantly is the argument that the financial reforms which underpin our health reforms are merely an accounting trick, which result in shuffling the same pool of GST revenue from one level of government to another for no net gain. I do know that the GST is an issue that evokes a lot of passion here in Western Australia, but I do need to tell you that this view of our reforms simply isn't backed up by the facts, and I'd like to take the opportunity to explain. Our proposals will fundamentally change the way healthcare is financed in Australia. Hospital costs are currently growing at almost 10% per year. GST revenue, which helps to finance these costs, is currently growing at around 6 to 7% per year. By taking on responsibility for funding 60% of these growing costs, the Commonwealth will take a much greater share of health costs into the future once the GST transfer is locked in. This will relieve states and territories of at least $15 billion worth of expenditure over the next 10 years by our estimates, or around $1.6 billion here in Western Australia. And the reforms can also have a direct benefit for patients right now. We've got $351 million ready to inject into Western Australian hospitals to deliver more subacute beds, faster elective surgery and emergency department waiting times. As the Health Minister, I confess to some frustration at the current standoff. Both the Premier and the Health Minister in Western Australia have told us several times that they support the health content of our reforms. No doubt they agree with the health content because they know our health reforms will benefit West Australian patients, or think that there are benefits in national standards, targets and comparisons. Obviously, the government is still considering its options if getting Western Australia to come into the health deal simply does not prove to be possible. But we hope it will be possible because we want all of the country to benefit from the improvements to health and hospital services that we are confident our reforms will deliver. And we believe the best way to do this is in partnership with the states and territories. All of us understand that this great state deserves to be looked after, deserves its fair share from the federal government, and I completely respect that West Australians will stand up for themselves. And that's certainly been a feature of our federation since its rocky inception in this state. I understand West Australians wanting to fight for their fair share. No one understood this better than John Curtin himself, someone who was strongly against the move for secession in the 1930s, but someone who still argued that Western Australia should get its fair share. What worries me is that Western Australia might miss out on its fair share if the current standoff over health reform is not resolved. Premier Barnett has said recently he's content with Western Australia having a separate health system from the rest of the country. But that means Western Australia won't get the benefit of increased federal funding, won't get the benefit of activity-based funding, and won't get the other benefits that flow from our reforms. Premier Barnett keeps saying that this isn't an issue about health, it's just about the GST. But the truth is, it is about health and the future well-being of the West Australian community. I believe that this is an opportunity that is too good to be missed. I hope that the opportunity will be seized, and I very much look forward to continuing to work with the West Australian Government to find a way through our current impasse. Thank you for having me here today, and I'm happy to take questions.
Thanks very much, Minister. We've got a couple of roving microphones floating around somewhere soon, so can we please indicate, put your hand up and say who you are and where you're from, just in case you're a plant from John Barnett's office. I'm sure you're not. We do have various people from the public service as well, so feel free to ask questions and the Minister's raring to go. So we've got one over here.
Hello, Minister. I'm Linda Shields. I'm the Professor of Paediatric and Child Health Nursing at Curtin. I've heard you speak on this before and I've read many of the documents. One of the things that concerns nursing in particular, and those of us who are working in community, is that there seems to be a misunderstanding between primary care and primary health care. And your model of funding primary care through GPs would reflect that. Can you comment on that?
Thank you. Yes, it's one of the things that I have a very strong memory of from the first days of when I became the opposition health spokesperson, a person without a health background those many years ago when that happened. And I can remember saying to one of my advisors, why are people talking about primary care and primary health care? What difference does it make? Aren't we talking about the first point of call that people come to into the community? And luckily, I had a very wise advisor who said, no, there's a lot of politics in this, and it's about the GPs and it's about the other health professionals. I must admit, I don't care especially for the terminology one way or the other, but I do disagree with your view that our funding is just going to GPs. In fact, from the 1st of November, Monday this week, the first changes for new categories of health professionals to be able to directly access the Medicare benefit schedule and the PBS were instigated only from our work and against a lot of opposition, because we saw that nurses and midwives were sufficiently qualified in this country to be entitled to access that sort of funding, and therefore for us to support what will be a growing area of practice for many nurses who perhaps have not considered it as an option because of the financial barriers that there were. But I think there's two sides to this argument. I think we should reform the system to allow nurses and midwives and other allied health professionals to get more recognition for their skills. But I'm unapologetic about wanting to support GPs. We actually have a good system of GPs in Australia. We have very high trust. Most people have a regular GP, not all by any means, and some big exceptions, as Fiona would be aware of, in our Indigenous communities. They are a good conduit and referral to other health professionals, and they are very well trained. So trying to reform the system that maintains and supports and builds on the strengths of what GPs do, but actually opens the doors a bit wider for other health professionals that have been left out, is a balancing act. But I think the view that we're only doing things through GPs just doesn't stand up to the quite historic changes that were implemented even just this week. Wouldn't be right to come to Perth without Fiona asking a question.
Thanks very much, Nicola. And I just commend the holistic nature of the health reforms that you've outlined and that are on the table, because you're attempting to address the pathways into disease as well as treating or coping with the huge levels of chronic disease and the ageing of the population, etc., that's going to be facing us. And I think that it's the holistic nature of that is great. And if I can just make a supportive statement to Linda, that I'm very, very supportive of nurses and midwives having a greater role. And I think that is part of the solution, not just in remote communities, but actually in the general community, and that there is an over-medicalisation of births, for example, which has led to unnecessary caesarean sections and a rising rate. We're the highest rate in Western Australia of caesarean sections. Probably at least half of these are not necessary, and if there was a greater role of community midwives, they wouldn't happen. And I do think that's we've probably done one of the best studies on home births in Australia many years ago to show that they were incredibly responsibly handled by midwives. And I do think that those data need to be looked at, and obstetricians have to relinquish low-risk deliveries to midwives and trust that they will be good outcomes. But I do think that's terrific that you've enabled those supports for midwives and nurses to happen. My questions sort of relate to the quality and evidence base, which I'm really pleased that you have got a commission to look at.
We've got it through the lower house. I don't want us to get ahead of ourselves. We haven't got it through the Senate yet.
But I mean,
perhaps Judith will help us with that.
It is just, I mean, looking at the evidence that we have on the effects of healthcare, quite a proportion of what we do has either no evidence of effectiveness, or there may even be evidence of harm, and yet we continue to do it. I'm not quite sure of the proportion in other areas, but in the paediatric area and the obstetric area, something like 70% of the drugs prescribed to pregnant women and about 80% of the drugs prescribed to children have no randomised controlled trial evidence of effectiveness or harm, and yet are increasingly being used. And so I think, it is absolutely crucial that we get the best evidence that we can around that. And I think that, therefore, that's another way of terrific cost control. If we can eradicate those things which are harmful, my God, that's really important, but those things which are useless as well. And I think it would be very interesting to see how that committee is going to function, and I'd be very interested if you could just give us a bit on that. And the second comment that I guess I want to make related to that, I mean, I'm
going to be struggling to remember any more questions
sorry.
if you go for much further.
I mean, I was going to ask about e-health, because e-health to a certain extent is going to help with that enormously. And that is that we have, as you know, a system of record linkage here in Western Australia to be able to link health records to things like the PBS. And we have the ability, therefore, for pharmacovigilance second to none in the world. And yet we have been blocked getting Medicare data and PBS data by the Commonwealth for reasons I don't understand. And if they are to do with privacy, we haven't had a breach in 35 years of record linkage in Western Australia. So I don't know if you can answer that question, but it is very frustrating that we've done the feasibility to show that that would be a wonderful way of getting evaluation of adverse effects of drugs, and we're being stopped to do it.
Yeah, thank you. I'll try and cover a range of those. Obviously on e-health, we do think that there is an enormous world to be opened up, and it is true to say that governments of all colours before us have really not been prepared to bite the bullet and plan far enough ahead. And it is hideously complex, it's hideously expensive, but it is hideously important. And we've been able to get the money to do that, and that we have the determination to do that. But you touched upon the privacy issues. There is a big, well, I don't know that it is a big group. There is a noisy group of people who are very concerned about the privacy consequences. And I do think it's one of those areas where you can derail what is a very positive reform if you don't move carefully to be able to reassure people at every stage of the way that it will be patient controlled, that you'll be protected, that if it's going to be used for research, that it's de-identified, all those sorts of things. And I think those assurances are not difficult to give, but I think we need to work through the process of building confidence in it, because it's one of those things that if something went wrong early, you would kill it forever, when actually we, I think, have a huge opportunity in front of us. I remember being briefed very early on about the requests that had been made for the data, and I think the reticence, I can't answer for previous Commonwealth governments, was always about not having taken this next step for electronic records either, and not really having thought through a decision about whether it was going to be sort of government-owned information or patient-owned information. We've been very clear that we want it to be patient information that your approved health professional can access, or other people, if you agree, can access. And what we actually know is that people get very confident very quickly. People with chronic diseases who actually want a range of health professionals to have access to their information will give that permission quickly, and they will become the advocates in the community. I just think it's one of those things where you have to be prepared to take people along with you, which means it's a bit frustrating if you've had a vision from a long time ago about where you could be. But I'm optimistic that we can keep working on those issues together.
Safety and quality, evidence-based policy issue.
Yeah, well, the Safety and Quality Commission, many of you have worked with already in its temporary format. It's been running for 4 years as a temporary organisation. It's done some good work. It doesn't have the authority that it would have as an independent body that all the states and territories have signed on to. That's why we'd like it to be set up as a permanent body with its permanent budget at arm's length from government, so that its guidelines, its rules, its range of other things actually need to be adhered to, particularly for the states and territories who at the moment, although they had agreed to the temporary body, can say, well, that's part of the Commonwealth's Department of Health, rather than a sort of standalone, credible, quality body. And the legislation specifies the types of people who should be on that body and how it would be set up. I can easily get that to you. But I think it's a good opportunity to be able to really give it some teeth. I think it's done a good job in the circumstances it's been in, but it's time now to let it grow to the next stage of development, I think.
Thank you. Jill Downey, Pro Vice-Chancellor of Health Sciences at Curtin. Thank you firstly for your presentation today, and congratulations on the reform agenda. Certainly we believe moving in the right direction. I'm very interested in clinical placements for our health professional students that will make up the workforce, and I think the implementation of Health Workforce Australia has been very widely supported and very much appreciated, not only within our university, but I know from universities across Australia and health agencies. Certainly the $420 or so million that you've talked about being distributed has been welcomed, and it certainly is going to fund growth for student clinical places. Sometimes what happens with policy, though, is that there are unintended consequences of that policy, and while that policy is funding growth for clinical placements, one of the things that's happening is that private organisations and public who take our students for clinical places are now asking for additional funds to sort of match what the Commonwealth is putting into the new places for growth. That's an extreme burden which won't be able to be borne by any of the universities that I know of, and certainly it's a concern for PVCs Australia. Are you able to comment on that? Is the funding for our previous or old clinical places, as well as our new, is that going to come in the longer term from the 60% of funding for education and research that the Commonwealth will fund?
Look, I think, thank you for that question, because I think it's a very foolish approach if organisations are now starting to revert to, I mean, one of the reasons in the past that the Commonwealth, not when we were in government, but was never persuaded to put money of its own, Commonwealth taxpayers' money, into the training system was because they argued that the tertiary funding that was provided to universities and states was meant to include placement money, training money for clinical placements, and that those arrangements have been sorted out for a long time. What we've seen, because we've got such a shortage of so many health professionals and there are a much larger number of people being trained, which is good, is everybody feeling squeezed. Universities feeling they're not getting enough money, hospitals feeling they're not getting enough money for their work, and the thing that always gets squeezed is who's going to actually provide for the training for the new interns or for the psychology placements or for others. So we saw this critical need, and it was something we invested money in very early on. So it was in a 2008 COAG agreement where we said we're not planning properly, we don't know where all the placements are, we don't know how many people need placements. The Commonwealth is prepared to fund a bigger share of it, but you've got to maintain your effort, the states and other players. So all the money that we have invested so far has been to increase capacity. Most of it's being spent on infrastructure so that there's more facilities in primary care and simulation facilities at universities and in private hospitals and in some more creative settings, even in our public hospitals. But we're just going to be on a downward spiral if everyone says, oh, because we've finally got some more money we needed in this area, now we want more money as well. People will never be able to keep up. But the longer term change will be assisted by the 60% funding, because although I focused on the sort of activity-based funding and giving the examples of paying per hospital procedure, we've agreed for the first time that we should pay 60% of all training and education costs in our hospitals as well. 60% of research and 60% of capital user costs. So it's actually 60% of all of these things that previously were just in the big bucket and you were expected to do. And we believe it's a way of, again, being able to have a bit more transparency that people should properly allocate for training as part of what you need to do in a hospital or other health service. But I think we might have some rough times ahead because we do have, like here in Western Australia, a very big increase of medical graduates coming online. We want more nursing students and others. We're going to have to find creative ways to make sure they get proper training experience in different settings where we know we then expect and want people to go and work. And that means, having proper training systems in aged care, facilities, which we've never done before, but we actually need thousands of health professionals working in aged care. So we had some money in the budget for that. So I think we're trying to be creative in the way we expand the settings. We're going to need a lot of goodwill to continue, though, from the hospitals and other health service providers, or the whole system really will fall apart.
Hello. My name's Alistair Marchese. I'm just a student from UWA.
Not just a student, very precious, our students.
Yeah, well, not as esteemed as yourself, I don't think, in my student career as yet.
May well be more help to a patient, however.
I doubt it. I have a couple of questions, if you don't mind. And they both hit on a couple of topics you talked about there. The first is to do with the idea of federalism, and I think, although you say your background's not in health, it's in law. What is your concept of federalism? Is this an outmoded concept that's no longer applicable to Australia as we move towards things like this, where the Commonwealth funds more of services that are delivered to Australians than the states? And secondly, your analogy of the activity-based funding body that sets the prices, the analogy with that to the Reserve Bank, and you mentioned the transparency aspect to it, but also the Reserve Bank obviously has the accountability aspect as well of its objective criteria of the inflation target. I wonder where's the accountability, I should say, of your body. Which is an important element.
Thank you. Well, I mean, it would be set up as a body that still needs to come and present, for example, to Senate estimates. Judith, who's here, knows that it's a process to be able to hold organisations to account, have proper audit abilities, all of those sorts of things. It's true that it won't have any as simple measure as the Reserve Bank about where inflation is or how the economy is travelling, because health is going to be a complex beast, and the way you price all of your services is pretty important. And the legislation would not get through the Parliament, nor would we seek it to try to get through the Parliament if you didn't have a whole lot of, safety valves built in there. There will have to be ways that states and territories and others can indicate if something gets completely out of whack. But the contrast is the system you have now, based, for example, in Victoria, when Jeff Kennett decided to introduce activity-based funding, closed a whole heap of hospitals, said, here's the pot of money. At the moment, we know this much activity happens, divide that in this way, right, that's what we'll pay for each type of activity. Never actually calculated on the basis of how many nursing hours do you need for something, how many rehabilitation hours do you need, what sort of medical intervention or equipment do you need. That sort of rigorous process we think needs to be put in place. My view of federalism is that if we as a room now were the founding mothers and fathers of federation, would you try to create the system the way it is now with the knowledge we have now? Probably not. But we have what we have, and I actually think there's quite a few strengths in federation. I think although there are occasional hiccups, and I regard us as being in an occasional hiccup at the moment with Western Australia, by and large it's a good opportunity to be able to test out and try out differences. Mostly states actually share their information quite well, and when something's worked well in one state, other states are not shy about adopting it. But improving what can work nationally, especially with new technology, especially with new information, there's no reason that whatever the appropriate clinical guidelines are for heart transplant should be different in Perth to what it's going to be in Brisbane, and trying to recreate some of those things in every state and territory is just a bit silly. So I'm kind of in the middle of the argument. I think that we could do more things nationally that make sense, but I don't believe that we should do everything nationally. I have no aspiration for taking over the states, and I think that there is many strengths in what the states can do, but getting that balance right is always difficult, and that's probably why we're in the healthy argument that we're in at the moment, which I hope will have a healthy ending.
Thanks, Nicola. Neil Fong from the Curtin Health Research Institute. Nicola, you've talked a lot about the reforms, and I think you've given us a really good overview of the reforms, in a sense, individually, and you've said there's been very good support even from this state who's not signed up to the actual health reforms. I was just wondering whether you could spend a little bit of time articulating how some of the reforms actually fit together, because if there's some criticism, it might be that they're not flowing together. And in particular, you might like to expound on the connection between the local hospital networks and the Medicare locals, and how that's actually going to make a difference. And in particular, maybe bring in the ABF as well as a mechanism to actually drive the change in spend of health dollars. Because at the moment, if you just looked at ABF and you're going to spend 6%, no one's actually said it's kind of like an unlimited amount that you could potentially spend in hospital services, unless you're going to actually have explicit purchasing decisions overlaying that. So I'm just wondering if you could kind of maybe just spend a little bit of time explaining that, because we are interested in the systematic reform.
Yep, sure. I mean, the real benefit I see in the activity-based funding, provided you build in protections which we have committed to for smaller regional hospitals, which will not necessarily ever be able to operate excuse me, at the same efficient price as you have for a national price. The real beauty is not just in knowing what you're doing in the hospital, but it means that for the first time there will be a health minister, a finance minister and a treasurer, at least in one jurisdiction, who will be able to say, hang on, it doesn't make sense for us to keep spending a growing amount of money in hospitals, where if we just bit the bullet and spend a bit more in primary care, we could actually reduce demand on our hospitals. We've never had that before. We've never had, around one cabinet table in the country, anyone who has that mix of financial incentives in the one room. Because for the states and territories, they've got no choice. They've got to meet the hospital demand. They get beaten around the head when things don't work, and they just have to find a way to make it work. And some of them then do look at things outside hospital to help relieve demand, but they're really only doing it because it's the way to try to take some pressure off themselves. At the Commonwealth level, where we've got the major investments in primary care, it's always been impossible to mount the argument that just because it's good for better health outcomes, that it's financially sensible, because if we reduce pressure on our hospitals that we don't currently fund for any activity basis, all we're doing is giving a windfall to the states because we've already agreed to their block amounts of funding. So that should not be underestimated as a very big reform in how you can make sensible decisions around health spending and health outcomes. I think that the fact that we're trying to do so many things in our reforms and that we're asked to explain each of them does sometimes mean you don't get that whole picture. So for the Medicare locals, which will be able to be established here in Western Australia, because they're Commonwealth funded, they're for GP services, their best impact would be if they've got the support of the states and territories as well, but nevertheless they could be implemented. Our intention is that the Medicare locals' main job will be to get, and I think it goes back to the very first question, much better and stronger relationships between different types of primary care givers. So whether it's GPs, whether it's nurses, whether it's community nursing, whether it's mental health providers, whether it's Aboriginal medical services, we've got nothing at the moment that can try to bring those services together, not to be run together, but to coordinate with each other and complement each other, and to plan for a local area and say, hang on, in our local area we don't have any psychologists and we have no podiatrists or a paediatrician. What can we do to actually fill in those gaps? What can we do to plan for keeping our community healthy? What sort of preventative health initiatives could we be? It's really hot here in WA if you've already got flies. So that's really important, and we have had an argument with people saying, look, if you're putting local hospital networks in smaller regional areas, isn't the most sensible thing to put them in a partnership with primary care organisations as well, look after a whole community's healthcare needs? And I think much longer term that is probably a good idea. But I know if you did it now, that all of those very disparate primary, now I'm worried about getting it the wrong way around, primary healthcare, everybody working in the primary care sector, primary healthcare sector, anyway, you know what I mean, will just get swallowed up by the demands of the hospitals and the better organised advocacy by hospitals. So I see that you have to sort of have those more regionalised structures starting. I hope if they work well, that maybe at some point in the future you would join them and you would actually genuinely be planning for what sort of hospital needs there are in a broader region and what sort of other healthcare needs there are in a region. But I think we've got a fair bit of capacity building to do first before we can do that. So, I mean, that doesn't give you the whole broad brush, but hopefully it might explain it for those. How are we doing?
Probably time for maybe one last one. You've got one? Here you go, one last one.
Minister, hello. Barbara Horner, Centre for Research on Ageing at Curtin University. Thank you for your presentation. It's been very interesting and very useful to hear an explanation of how all of those components of the reform pull together. My question relates to your ageing portfolio. It's a very interesting and a very difficult and challenging sector, and we are seeing some great reforms, and we're seeing industry providers working very, very hard to do things well and to do things differently, and we probably still have one of the best systems that we could possibly have, even though it still has areas of frustration for many of us. I'm wondering if there's going to be an opportunity for funding to be designated for some demonstration models of new models of care, new ways to deliver aged care services, particularly in the residential area. It's an area that we've had some encouragement to work on, but without some designated funding to some of the providers who really have some fantastic and creative ideas, it's quite difficult to put some of those reforms in place.
Yeah, thank you. That's a good suggestion. I might just make sure that one of my staff who's here grabs a card from you, because it might also be useful to talk to Mark Butler, my colleague who is the Minister for Mental Health and Ageing. We are interested in looking at innovative models, and you're probably aware in this audience that we have the Productivity Commission currently undertaking a review of the aged care sector, and I think there are some pretty difficult issues about how that sector is going to be viable into the future, meet the demands of the population, turn itself into a different type of service into the future as baby boomers have different expectations and all sorts of other things. One of the not very often spoken about changes that was agreed to as part of COAG is that we at the Commonwealth level are taking on full responsibility for aged services. Obviously, we've already always been funding the residential aged care, but we've only partly funded HAC services before. And part of the reason we were so determined to take over that completely in aged care is we feel that there is a broad spectrum between what a very targeted community care package can provide and what very intensive residential care can provide, and no one's done much work about what could go in the middle and might be a better type of care. What could you do in providing more care at home? Should we separate out the cost of care and the cost of accommodation because they're two different things? Are there other ways to look at this? And we think the Productivity Commission will give us a lot of information, but we're not thinking they'll give us all the ideas. So I know Mark is very keen to hear about different models, talk with different researchers, see what other ideas there are, and we believe that we'll have to look pretty creatively. And this term's agenda, for me, is trying to bed down all of the extensive reforms that we have, and we've specifically tasked Mark as an additional minister in the portfolio with two of the areas where we need some creative new change in mental health and in aged care, so that we can keep the momentum moving where there are other needs for reform, but we can still concentrate on the very big implementation task that we have for the reforms that have already been agreed. So Chris might duck over and get your card, or Jessie, I think, is in the back there to do it. Thank you.
I'd just like to ask